Фостер Брюс Клеминсон. Использование морфина для обезболивания. Возьмите, пожалуйста, все устройства для перевода. Брюс наш старый друг. Мы к нему с большим уважением относимся. Книгу, которую сделал Брюс специально для России по паллиативной помощи, она также есть в раскладке. Преподаватель, ведущий тренингов, врач паллиативной помощи, член Королевского колледжа общей практики, координатор образовательных программ по паллиативной помощи в Великобритании. Так.
It's a great privilege to be here today. So thank you for inviting me. You got to translate?
Там есть синхрон, все есть, Оль.
Of course, simultaneous. In 1967, Dr. Cicely Saunders in London, in England, opened the first modern hospice in the world with evidence-based palliative care being developed and provided. In Britain, there are now many hospices and palliative care units, and because of the recognized benefits this kind of care has brought, it has spread worldwide. Since 1990, palliative care has been developing in Russia, and this is being provided through hospices and palliative care units. In Britain, doctors were allowed to prescribe parenteral and immediate release morphine before the start of the hospice movement in 1967. Sustained release morphine came later. But in Russia, we have been allowed to prescribe parenteral morphine for many years, and sustained release morphine has arrived more recently. And next year, 2018, immediate release oral morphine is due to be launched, and hence this talk. But many people are afraid of opioids, and in particular, they are afraid of morphine. So first of all, let us try and reassure patients and families, medical and nursing staff, and the authorities that opioids can be safely and effectively used. I started using morphine, prescribing morphine, and its prodrug diamorphine for relieving pain and life-limiting illness in 1974, while I was training as a palliative care doctor under Dr. Saunders in London and England. I've been teaching about the use of morphine and diamorphine in the management of pain in life-limiting illness since 1974. The World Health Organization has stated that morphine in oral immediate release and oral release, sustained release and parenteral formulations, morphine is an essential medicine for pain management in palliative care. Not just an add-on, it is an essential medicine. In 1990, in Russia, the first hospice was opened in St. Petersburg. And here in Russia, for many years, we've been using parenteral morphine and more recently sustained-release morphine for the relief of pain in life-limiting illness. In 1996, the WHO released the three-step Analgesic Ladder. And this is to help doctors to use morphine, opioids like morphine for pain relief in a careful and safe way. We can be assured from international experience, from Russian experience, and from the directives of the World Health Organization that morphine is not only safe, but is essential in our work in palliative care. Do we need to use morphine in the management of life-limiting illness and pain? Well, 70 to 80% of patients with incurable cancer will receive opioids at some time during their illness for the management of ongoing and constant pain. Patients with other kinds of terminal illnesses will experience similar prevalence of pain, and they will also need opioids. For people with cancer, the pain is not only experienced towards the end of their final illness, but 59% have pain during the curative treatment, 33% have pain after their curative treatment, and 65% have pain when their illness is more advanced. So opioids will be needed by most of our patients who have life-limiting illnesses. And morphine is the gold standard, zolotaya marka, for the treatment of opioid-sensitive pain. Now, not all pains are opioid sensitive, and there are more appropriates for some of these, things like colicky pain, the pain caused by raised intracranial pressure, and neuropathic pain. These have different and more effective treatments. But to help physicians manage the kind of ongoing opioid-sensitive pain, the WHO published a simple analgesic ladder in 1996. And using this ladder, patients with mild pain should be started on step 1 analgesics, and as the pain increases, it should go from step 1 to step 2, and then from step 2 to step 3, as needed. Now, there is a correlation for untreated pain with the 0 to 10 numerical rating scale for pain, especially in the one called the Brief Pain Inventory. And so there's a correlation. Mild pain is 1 to 4 on the 0 to 10 scale, and then moderate pain is 5 to 6, maybe 5 to 7, and severe pain is 7 or 8 to 10. So there's a correlation between the levels of pain and the score on the Brief Pain Inventory. So when we're thinking of starting somebody on analgesia, we need, first of all, to hear the patient's story. There is no magic test for pain. We have to listen to what the patient tells us. And we need to hear what they're taking for their pain just now, and how effective is this treatment being. And that's where the Brief Pain Inventory can be really helpful, because we can take the score, and then later, after treatment starts, we can take it again and see what the difference is. Step 1 on the WHO analgesic ladder: paracetamol, ibuprofen, relatively safe, relatively non-toxic medical treatments. Step 2, weak opioids. Weak opioids in Russia means tramadol. I don't think there's another choice. And these are medicines which have a ceiling effect, in the sense, I'll show you a picture in a moment at the end of this little section, how, first of all, there's a dose-response curve which goes up, so the more tramadol you give, the more pain relief is experienced. But then it flattens out, so the more of tramadol given, there's no further pain relief, but there's just more side effects and more interactions and more problems with tramadol. So you get up to 400 milligrams, and then it flattens off. So there's no point in going further than 400 milligrams. Now, at that dose, at 400 milligrams of tramadol per day orally, it's equivalent to about 25 to 40 milligrams of morphine orally. Now, that is a very low dose. So you can see that if it's equivalent to that, you could, in fact, if you wanted to, miss out the tramadol stage and go straight to a low dose of oral morphine. And in fact, in children, that is the preferred option, to go from step 1 to step 3, because you don't want to have this middle bit, which is not so predictable and not so useful in children. So you go from paracetamol, ibuprofen, to step 3 opioid like morphine in one go in children. But for most of us in the world, step 2 analgesics we feel more comfortable with them. They're easy to handle. The regulations are different for step 2 than step 3. And so we actually prefer, and patients prefer, to go step 1, step 2, step 3. But in some places, even in adults, step 1 to step 3 is preferred. Let's see. So when you get to 40 milligrams 400 milligrams of tramadol, and if the pain is not relieved, and you know that this is opioid-sensitive pain, you need to step up to step 3 analgesics. Could you give the picture of the... there we are. That's the typical curve showing tramadol with a cessation of analgesic effect when you increase beyond 400. So analgesia stops at that point, at the 400 level, and all you get is more problems, more side effects, more symptoms from the tramadol. Step 3 opioids. Morphine is the gold standard. That is due to familiarity, availability, and cost. At the present time in 2017, there are in Russia areas of higher uptake and areas of lower uptake. I'm going to put this away, hang on. There are areas of higher uptake and lower uptake with regard to morphine, oral morphine at this moment. And in some areas you have more prescriptions of sustained release morphine and other areas less. Mainly Moscow and St. Petersburg, big cities like that, have a higher uptake, and mainly the rest you don't. But it's, as we saw yesterday in the pictures from the Health Authority, the Health Ministry, it's not quite so clear as that. When considering how to prescribe strong opioids, we should remember that the oral route is the preferred route for providing analgesia. It's the normal route for medicines, it's the common route, and it allows people to live as independently as possible. Remember, long-acting preparations of step-3 analgesics are used preferably for the treatment of stable, treated pain. They're not so good for titrating pain, they're good for maintaining pain control. Patients with ongoing pain need ongoing treatment, like with diabetes, like with asthma, ongoing problems, you need a regular ongoing treatment, ongoing pain, ongoing analgesia. And all patients on opioids ideally should have a PRN, a dose of immediate release morphine in case of breakthrough pain. I'm going to go on to 14, slide 14. Oh yes, you can show that, yes. And here, that is the picture of the morphine type, the straight line. The more morphine you give, the more pain relief is experienced, and there's no flattening as in the step 2 analgesics. So step 2 flattens, step 3 straight line going on upwards and on upwards off the graph paper, for a long way. Okay, slide 14. Parenteral is the same, yeah. Parenteral morphine. When parenteral morphine is used, it's because oral morphine is either not used or not appropriate. Step 3 parenteral morphine is usually given subcutaneously when used for pain management in palliative care. It means that you don't have to give it IV, it's easier, it's safer, especially in the home setting. Parenteral morphine is very useful when people cannot swallow for one reason or another. Parenteral morphine is twice as potent as the same dose of oral morphine, and this is due to the first pass effect. If you take morphine into your mouth, swallow it, it gets absorbed and passes through the liver. There's a bioavailability problem in the stomach, some of it doesn't get absorbed, and of the rest that goes through, some gets degraded on the first pass through the liver. So that's why it's called the first pass effect, and half of the ingested morphine never reaches the systemic circulation. So when you have an injection of morphine, you get twice as much into the body as the same amount given through the mouth. When using a syringe driver, morphine can be steadily given subcutaneously and provide a constant background analgesia. But when you start the syringe driver, it takes 4 hours for it to reach a steady state, because you start from 0 and it just pumps in morphine, a little bit more, until 4 hours you've got to a steady state. So, if your patient is in pain and you're starting a syringe driver, you need to give an appropriate dose of immediate release morphine to take care of the first 4 hours while the syringe driver is releasing more morphine and gets to a steady state. If a syringe driver is available, use it. They are wonderful, they're so helpful, they're kind to the patients, they're good for staff, good for families. But if a syringe driver is not available, then you fall back on every 4 hours giving an injection of morphine. Injections are not pleasant for the patient, and they're not pleasant for the family to give either. So if you leave a little butterfly needle in situ, some part of the upper body, then that can be given. You can give the morphine through a butterfly needle, which is much nicer for the family and much nicer for the patient. Let's see, 15, that is. You give morphine every 4 hours because it only lasts for 4 hours, the immediate release morphine. If you look at the graph of immediate release morphine, it goes up and it goes down. and it gets down below the therapeutic level at the end of 4 hours. So that's why you give morphine orally every 4 hours, unless it's sustained release. If you give morphine every 6 hours, if you don't want to have a pain at the end of every dose, you have to give more morphine, and you risk toxicity at the height of the peak before you go down to the trough. So if you don't want the patient to have pain at the end of the 6 hours, you have to risk toxicity from a high dose of blood level of morphine at the beginning. And if you only give as-needed medicines for this, the patient only gets the next dose of morphine when he experiences pain, and therefore every 4 hours he will experience pain. And as you only give the injection sometime after the pain has come, he'll experience quite a long period of pain before the morphine becomes fully effective. Breakthrough pain should be treated by a dose of 1/6 to 1/10 of the daily dose of morphine, either oral morphine or parenteral morphine. Should paracetamol be given at the same time as morphine or other opioid, step 3 opioid? It does work by different means. It may have an effect, but you've got to remember that probably for an adult you're giving 8 tablets a day. It's quite a big tablet burden, because there may be lots of other tablets as well that he's taking. So if you start opioid, you can then trial, if we add paracetamol, does it make a difference? If we take it away, does it make any difference? And most times, you'll find you can get very adequate pain relief without the paracetamol. So how much morphine will the average patient need? If you were to look at the median, well, look at here, this is diamorphine, which is twice as strong as morphine. But this shows that the average person, the median dose actually, the median dose is 30 milligrams of diamorphine orally, which is 60 milligrams of morphine orally. So if you look at it, half the people require less than 60 milligrams of oral morphine per day, and the other half require more. So the median dose is 60 milligrams of oral morphine given in divided doses, either every 4 hours or with sustained release oral morphine twice a day. Now, let's look at practice in Russia today, 2017. There are, as we said before, areas of higher sustained release morphine uptake in Russia and areas that are lower. The Hertzen figures in 2008 were very dramatic. It said that at the highest levels of 30% of people who needed morphine were getting it orally. And outside of these areas, it was only 1.9%. Now, I think from what I heard yesterday, probably this has changed a bit. But it's still got a long way to go. So we've got areas of higher uptake, areas of lower uptake. If you live in an area of a higher uptake, as a doctor, if you prescribe sustained release morphine, either MST tablets or sustained release morphine generic capsules, you're more likely to be able to find it because it's been ordered for you and it's in the pharmacies. So in these areas, Ivan comes to you and he's in untreated, uncontrolled pain. The history and your examination makes you feel this is likely to be opioid sensitive. You do a pain assessment using the brief pain inventory. If the scores are low, 1 to 4, you should try tramadol. Start with 50 milligrams 4 times a day, and then see the next day, what effect has that had? If that's not had a very good effect, double the dose to 100 milligrams 4 times a day. Go back 24 hours later, see how that's been going. If tramadol 100 milligrams 4 times a day has not completely abolished the pain, Ivan needs to have a step 3 opioid. And remember that the zolotaya marka is morphine. So you go from tramadol to morphine. What do you start with? Let's see. If you start, you should not start with more than the equivalent dose of if you've got 400 milligrams of tramadol, the most you should go in at is 40 milligrams of oral morphine. Because, as you know, tramadol, the metabolism of tramadol into its active component, because tramadol is a prodrug. Its conversion into the active drug is variable. Some people do more, some people do less. And therefore, for 400 milligrams of tramadol, some people get more analgesia, some people get less. If you immediately, say, go from 400 milligrams of tramadol and give 60 milligrams of oral morphine, you may be giving somebody quite an overdose of morphine. So the best thing to do is to start at 30. Start at 30 milligrams, or even if you've only got 10 milligrams and 20 milligrams of 10 milligrams of MMST, give 20. See what 20 milligrams, 10 twice a day does. Come back the next day. If that's not worked well, increase the dose to 30, then increase to 40, increase to 60, to bring the dose of MST up day by day to the level that completely abolishes the pain and does not allow it to come back. The aim is not just partial pain relief. The aim is total pain relief. Now remember, the patient may have more than one pain. We're talking about the opioid-sensitive pain that the patient has, not the colicky gut pain or the neuropathic pain that he's also got at the same time. We're talking about the treatment of the opioid-sensitive pain with morphine. Once the pain has been totally abolished, you then know the dose of MST required, or sustained release capsules of morphine required for him to take in the longer term. Now, once the pain is completely controlled, and you've got the regular twice daily sustained release morphine, you can, if you wish, change to a fentanyl patch. But then you've got to think, okay, the fentanyl patch takes 3 days to really get to full complement of strength. It is also a more expensive system. It has more interactions. The only reason why you might seriously think about fentanyl at this stage is kidney failure. Severe renal impairment might be a good reason. But apart from that, there's not very much in its favor because it is much more expensive than the same dose of sustained release morphine. So for economy, for the patient's comfort, for just about everything, if the patient has got normal kidneys, give the patient morphine. Now, if you've got the patient on morphine, oral morphine, at some point, the patient is likely to begin to get more and more, just to go down functionally, and before he dies, he probably is going to be unconscious or certainly not swallowing for 2 or 3, maybe 4 days. If he's not swallowing for 2 or 3, 4 days, his pain has not gone away. You'll need to change to parenteral morphine. Now, parenteral morphine means either find that syringe driver, go to a different hospice, ring up your friends, have you got a syringe driver spare, get the syringe driver and put not the whole dose that you're giving as MST, but half the dose in per day, and that will take care of the patient's pain. Half the dose in the syringe driver is what you need. Or, if you haven't got a syringe driver, every 4 hours, a subcutaneous injection, preferably via a butterfly needle, to do the same thing. But it's harder work on the staff, it's harder work on the family, it's harder work on the patient. But there are lower areas of uptake of SR morphine in Russia today. And in these areas, in some of these areas, oral morphine is hardly ever used. Now, it may have gone up a bit since 2008, but it's not perfect yet. So you get to tramadol 400 milligrams, the patient is still in pain. So morphine should be started at an injection of 2.5 milligrams every 4 hours. That's 10 to 15 milligrams of parenteral morphine per day, which is the equivalent of 30 milligrams of oral morphine per day. If this is ineffective, that 2.5 milligram dose can be repeated every hour if needed to provide effective pain relief, because it's fully effective in 1 hour, and therefore if the pain is still there in an hour, he needs more step 3 morphine. But you'll say, and you're quite right, but this is a problem. I cannot give 2.5 milligrams of injected morphine. The ampoule is 10 milligrams. And I'm not allowed to only give a quarter of an ampoule at a time. If they find that I'm doing that, I'm doing wrong. But equally, if you give the whole 10 milligram ampoule, you could actually seriously compromise the patient, because that's 4 times your predicted dose. There's a problem. And can I just say, I'm really sorry that there is no easy answer. Any doctor who wants to give 2.5 milligrams of morphine by injection at the moment has got a problem, because either he gives too much morphine and is safe legally, or he gives 2.5 milligrams and he's not safe legally. And each person, each team will have to discuss this and think, what do we do? If you decide to go down the route of giving a little bit more morphine than is expected, then please go back every hour and check that patient to make sure that the patient is not sliding into toxicity. And if he is, well, I published a book last year in Russian. Read up the chapter in the book and you'll find out hints about what you might want to do. At the end of the first day with injections of 2.5 milligrams of morphine, then add up the dose, all the doses you've given during the day, add them all together, divide them into by 6, and then give that dose every 4 hours. So say, for example, say it turns out that you've given 6 doses and you've happened to give an extra 2 doses in between each one. That means you've got 7.5 milligrams of morphine each 4 hours. So that's the next dose for the next day, and that, of course, can be rounded up to 10, because going from 7.5 to 10 is not a big jump. Going from 2.5 to 10 is a big, big jump. So then, once you find out the dose for the next day, you give that every 4 hours. You see how the pain is responding to that. If the pain breaks through, you give breakthrough doses. And at the end of the second day, you should be able to round it up and find out how much the patient has had and whether the pain relief has been good. And by that time, it should be good. And then, of course, you can either give that whole dose in the syringe driver, run the thing through the 24 hours, or you can break it into 6 and give 6 injections through your butterfly every 4 hours to give pain control. But if you get towards 100 milligrams of oral morphine, that's 50 milligrams of parenteral morphine, you have to say to yourself, have I missed something? Is this really opioid-sensitive pain? Have I overlooked something? Could it be that I'm treating neuropathic pain with morphine, or is that I'm doing something else? Because 100 milligrams of oral morphine is actually quite a big dose. You need to just check. You can give more than that, but you just need to run the check again and say, am I doing the right thing? Now for the good news. Next year at this time, if what we've been told happens exactly on plan, we will all be able to prescribe oral immediate release morphine and oral sustained release morphine. Now that is good news. So, in this situation, Olga comes to you. She's got untreated and unrelieved pain. And the history and the examination make you feel it's going to be opioid sensitive. You start her maybe on tramadol, depending on how the brief pain inventory scoring. And if it still is not well treated, you move to a step 3 analgesic. Okay, now, this is the new bit for all of us. What do we do now? And this is the nub point. This is the part of this talk which is the new bit for all of us. You give oral instant release morphine, normal release morphine, every 4 hours. Okay? So, say for example, you got to tramadol 400 milligrams, and you want to give 30 milligrams of oral morphine. That's 5 milligrams times 6. So you start with 5 milligrams of immediate release oral morphine 4 times a day. And you write up as a PRN, as a kind of as-needed dose, you write up 5 milligrams, which have been given as often as every hour through the day, that the pain has either not been relieved or has come back before the next scheduled dose. So in other words, the patient's got pretty free rein to say, my pain is still there, my pain is still there. And just checking out that we're talking about the same pain, then he can have oral morphine for his opioid-sensitive pain. So you've given him that for the first day. You add it up Say, for example, he's had 5 milligrams of morphine every 4 hours, but he's had another 2 doses every 4 hours as well. So that's 90 milligrams of oral morphine in the day. And so you say, okay, the next day we'll divide 90 by 6, which is 15 milligrams. We'll give 15 milligrams every 4 hours. And we write up the PRN, the as-needed dose, is 15 milligrams. So 15 milligrams, maybe 8 in the morning, and you can have 9, 10, 11. You can have another 15 if the pain has broken through again. 12, he has the next dose of 15, 13, 14, 15, 1600 hours, 17, 18, 19. He goes on right through the day. And at the end of the day, you add it all up again, and you say, okay, he's needed the 5 milligrams 6 times a day, or whatever it was, 15 milligrams 6 times a day, plus 2 extra doses. So you say, okay, that's 120 milligrams in the 24 hours. And now you say, we have sustained release morphine now. So you give him 60 milligrams of sustained release morphine then, and 60 in the morning afterwards, and you carry on giving him 60 twice a day with a breakthrough dose of 20 milligrams if pain occurs between one sustained release morphine and the next. Okay? And it can be given as often as every hour, but it probably won't be needed that often because you've been very careful in titrating to get the pain controlled. Okay? So, very simple. With immediate release morphine and sustained release morphine, probably in 48 hours, the patient's gone from totally uncontrolled, horrendous, mind-blowing pain to complete control. And I've seen this happen. In St. Christopher's Hospice down in London, a man came in under my care. We kind of treated him with oral morphine. 2 days later, the first day, he couldn't do anything, couldn't get out of bed. He was in so much pain. 2 days later, he was walking around, just behaving normally. He was totally pain-free. He was just amazed. Now this is knocking on your door. This kind of very quick pain control should be yours in 12 months' time. Okay. I hope you're excited about that. I feel excited about that. I've been coming to Russia now and teaching palliative care for 20 years. And this is the first time I've been able to say, look, this time next year, this is what's being planned for you. That's wonderful. So get up, crack the champagne corks, get out the Black Forest gâteaux, have a celebration. It's worth a party. Okay. I get enthusiastic. Common side effects of morphine. Constipation. You put someone on morphine, you put someone on any step-free opioid almost, and they get constipated. Look, it's A follows B. Opioid and constipation are A and B. They follow each other, whatever happens. So when you start morphine, the advice is when you start the step-free opioid, you must have a propulsive laxative because it's the propulsion that the morphine goes for. It stops peristalsis. So you need a peristaltic agent. If you think of the strongest one, Gutalax, well, it's probably quite a strong one to start with, but at a very small dosage, that might be the one to go for because it is propulsive. If after a day or two nothing still happens, you need to add a softener laxative because things will be getting really stony and hard inside. Constipation, drowsiness. When you put somebody on morphine, they get drowsy. Most do anyway, and they're drowsy for a few days. Warn the patient, warn the family. If you don't do that, they're going to be terribly worried. You're poisoning my husband. You're poisoning my father. He's been asleep for 3 days or drowsy. No, say to them beforehand, look, the morphine we're going to give is very good for pain relief, but it will cause drowsiness for the first few days. So, look, don't be worried about that. He will, by the second half of the week, he'll be back to his normal self again. Third, nausea. Commonly, not almost always, commonly there is nausea associated with taking opioids. So, look, haloperidol is probably the one of choice. A teeny wee dose, 500 micrograms each day. Very small dose. That should completely relieve the nausea. And just take it for a week, then stop it. After a week, they'll not be having, at least, I've only met 1 or 2 that have gone on after that, but for a week, just give that teeny weeny dose of haloperidol for a week, then stop it, and most will have no problem. Dry mouth. Often people on morphine complain of a dry mouth, and having a glass of water beside the bed is often the answer to that one. More serious is morphine toxicity. Now, the first thing is mild toxicity, and this often shows itself in vivid dreams. Now, that's the kind of thing that patients don't tell you about because they think, if I tell them about those vivid dreams, they'll think I'm going crazy. Okay? So they won't tell you about that. But if you say, by the way, are you having any interesting dreams these days? Yes, I am actually. Now, you know, actually, I was in hospital having knee replacements 2 years ago, and I got given a huge overdose of opioids. And the family came down. They found I was hallucinating wildly. So if you want to have the further details, come and speak to me afterwards. I'll not go into it just now. But I mean, I can tell you, opioids do give great hallucinations. I mean, amazing hallucinations. And that was just about very practical things like Zimmer frames. And also wild dreams and mild myoclonus. People begin to just jerk a bit, just see these fairly big movements going on. And that's often mentioned because the families say, Dad's beginning to drop his tea or spill his tea, or they begin to drop things and spill things. And that's obviously sometimes the first sign of a bit of myoclonus going on. Now look, if you're watching out for these mild toxic signs, you're not going to get to the major toxicity stakes, which are really quite frightening. And they're very rare anyway, because most of us look, and if someone's developing toxicity, we take the right steps. Well, if you see mild toxicity, look for dehydration. Check for renal function. Look for infection. And just see if there's something there in the dehydration, in the renal function, in the infections that are pointing to why. And then treat the treatable. If something kind of encourage oral fluids, that will help to take out the active components, the active metabolites of morphine out in the urine. Sometimes toxicity is caused by pain going down, but the opioid stays up. So in other words, say if someone has radiotherapy and they're on quite a high dose of opioid because of pain. As they have radiotherapy for their spine, the pain goes down. And if you keep them at the same level of opioid level, they'll become toxic. So as the pain goes down, just try gently to reduce it and see how far you can go down without the pain breaking through again, just so you can keep the opioid roughly at the same level as the pain, because you want to balance it. You want to come up to balance it, and when it goes down, you want to go down to balance it. So the pain equals the opioid. If you're, for some reason, you're called to see a patient in a general ward or something like that, because someone says, I think this is a palliative care problem. You go through and you find the person is really quite opioid toxic. Maybe drowsiness or slurred speech or respiratory depression. These things you should not be seeing in your hospice or in your practice, because you should be looking carefully for opioid toxicity. But if you find this happens, then you've got to really be careful. And the respiratory rate is the main thing. If that's down below about 8 per minute, you've got to think about giving a little bit of naloxone. But you've got to do it very gently and very carefully, because otherwise you're going to throw the patient into a crisis of pain. So you've got to use the smallest dose. But you can get those details on the internet, and it's not for this talk. Addiction. Some people are very much afraid of morphine and addiction. But Robert Twycross, who incidentally was involved with the starting of Lachter Hospice in 1990 in St. Petersburg, he did a lot of work on morphine and diamorphine, and he looked at this matter of addiction very carefully. And here you've got the arrows are radiotherapy. You see this first arrow? And you can see that the person is taking about 300 milligrams of diamorphine per day. And you can see it coming down stepwise, right down to 0. And that is not uncommon. And you do not have a problem of addiction if you give opioids for pain. At least if you give them a complete cessation in one go, they'll go cold turkey. But that's a chemical reaction. It's not an emotional reaction. They're not emotionally dependent on opioids, because you're giving it to relieve pain and keep pain away. So you can see that you can step down the dose of opioid right down to 0 if the pain goes away completely, and there will not be any reaction to that, as long as you don't do it in a one fell swoop go. And tolerance, next one, please. Tolerance. Oops, there's not another slide? Yes, good, tolerance. People say, well, one of the people who I spoke with, a professor, said, but we keep morphine for the last few days of life because of the problems of tolerance. And tolerance, if you did this graph, this is the median dose at 3 weeks, 1.5 weeks, 3 weeks, 6 weeks, 12 weeks, and 24 weeks after diagnosis. The median dose for a series of patients, 418 patients. So if you look at the dose at 12 weeks, and look at the median dose at 24 weeks, they're almost the same. That shows no tolerance. If it was tolerance, it would be the other way. It would go along and up into infinity. But it doesn't, it goes like that, which shows there's no tolerance. The increase in morphine between 12 and 26 weeks is purely tumor growth, and therefore an increase in pain, therefore needing an increase in morphine. So, very impressive. No addiction, no tolerance. Somebody says, if you put my patient on morphine, he's going to die. You're going to shorten his life. No. There is no evidence worldwide that putting somebody on morphine shortens their life. In fact, the evidence points really in the other direction. If you relieve their pain, they feel better, they eat better, they sleep better, they actually are likely to live longer than shorter. So it's not just, shall I give them better life for a shorter time? It's, can I give them a better life for a longer time? Well, that's wonderful. It's win-win. Now, I'm going to give you an example just in my final minutes. This is a person from a way back about early 1980s, before we understood about neuropathic pain, because there have been such advances with that. And although morphine can treat neuropathic pain, you have to have big doses, and it's probably better to use other agents that are like anticonvulsants, which are membrane stabilizing drugs. My patient had pancreatic cancer, and for the last maybe 4 weeks of his life, his pain was very stable, and he was on 400 milligrams of MST twice a day. 400 milligrams twice a day. And I hope that's a higher dose than you'll ever have to prescribe, because it's not the kind of dose we prescribe nowadays. But we didn't know about gabapentin in those days. So he was on MST twice a day, and he had no alteration in dose. He had no pain. On the night before he died, he got out of bed, he walked through to the sitting room, he switched on the television, he watched international rugby, he watched wrestling, and he spent an hour happily in front of the television enjoying watching these international events. And then he went back to bed. Next morning, he didn't wake up. He was in coma, and he died at lunchtime. Now, all I do, I'm not saying that is to tell you you can prescribe a lot of morphine, but I'm saying even at that very high level of morphine, cognitively, he was okay. He enjoyed television. He could walk without help. He could even eat food, you know? He could dress himself. So it didn't shorten his life. It didn't reduce his ability. And therefore, especially if you're less than 100 milligrams, you don't need to worry about, is this going to do harm to my patient? Very occasionally you may get some reaction, but morphine is a wonderful drug. It's a safe drug. It's an effective drug when used carefully and well. So next year, guys, this is going to be tremendous. Coming your way, immediate release and sustained release morphine. Isn't that amazing? And available in all the oblasts of Russia. Isn't that amazing? Yes, it's fantastic. Come on, let's say yay. There you are. Thank you for listening. Thank you for laughing. Thank you for, I hope, enjoying this breakthrough situation of morphine.
Спасибо огромное, Брюс. Уважаемые коллеги,
If you want any questions, I'm here.
уважаемые коллеги, есть ли вопросы к Брюсу? Да, Зоя Анисимовна.
Вам в практике У нас пациенты разные, и бывает очень трудно корректировать болевой синдром. Скажите, пожалуйста, какую максимальную дозу вы в своей практике использовали при назначении парентерального морфина, инъекционного?
Yes.
Морфин практически не имеет предельной суточной дозы или предельной дозы.
Thank you. Yeah,
Как,
I understand. Thank you. Я понимаю. The question is not the maximum dose of parenteral or oral, because if you give parenteral dose, you should just halve the dose. So it's the maximum oral dose that I've ever used or maximum parenteral dose, because the two are linked, as I've mentioned before. And the highest dose that I've used is 400 milligrams of MST twice a day, which is the equivalent of 400 milligrams of parenteral morphine a day. Now, but you shouldn't, that would be very rare nowadays, because it was because I didn't understand neuropathic pain that I treated pancreatic pain with morphine in that way. Normally now we'd use, throw in a bit of gabapentin and things, or even do nerve blocks, celiac plexus block, or the other blocks you can use. So I mean, you wouldn't need that kind of level of pain. And pancreatic pain probably is one of the most severe pains you can have. So that is for me about 800 milligrams of oral morphine, 400 milligrams of parenteral morphine per day. But you shouldn't need usually to get that high.
Спасибо вам большое, уважаемые коллеги. Спасибо огромное, Брюс. Уважаемые коллеги, для того, чтобы в каждом субъекте Российской Федерации появился морфин, главные специалисты совместно с местным Минздравом уже в июле этого года, 2018, не дожидаясь чего-то, должны в своей заявке в Минпромторг это-то отметить. Поэтому Брюс не будет следующей осенью у всех морфина, точно, потому что большая часть субъектов в своей заявке не напишут этот морфин, к сожалению, опять. И мы только в 2018 году, когда вспомним, что мы не написали это летом 2018 года, наверное, напишем летом 2019 года, и тогда, наверное, в 2020 году. Вот так не надо делать, поэтому мы завтра это тоже будем обсуждать на профильной комиссии. Появление нового препарата должно нам сказать о том, что мы с вами уже этим летом должны сделать правильную заявку через Минпромторг на следующий год. И еще, что заявки корректируются. Если в июле в этой заявке морфина не будет перорального, то нам с вами можно будет и в течение года дозаявить. Но этой функцией тоже мало кто пользуется, и чаще всего одна заявка в год подается в Минпромторг, и дальше не дозаказывают субъекты. Поэтому радостно, конечно, все, но не так радужно, как Брюс вот думает. Для того, чтобы это появилось на всех территориях субъектов Российской Федерации, не хватает того, что зарегистрирован, произведен, нам надо еще его умудриться доставить, заявить, пробить. Так что не успокаиваемся, продолжаем трудиться.
Можно мне два слова добавить? Дело в том, что вот наш отечественный морфин, который производит Московский эндокринный завод, наши институты, еще несколько учреждений проведено, заканчивается сейчас многоцентровое клиническое исследование с фармакокинетикой, очень сложное, серьезное, которое стоит безумных денег. И вот наш институт уже закончил вот эту часть с фармакокинетикой, и я не могу раскрывать всех подробностей, но в целом впечатление от препарата очень хорошее. И несмотря на то, что это не морфин-сульфат, а морфин-гидрохлорид, я думаю, что вы поймете, насколько удобно и безопасно им пользоваться. Мы, правда, пользовались не таблетками не по 5 мг в нашем исследовании, 10 мг, но я вас уверяю, мы ожидали больше побочных эффектов. Вообще все пациенты прекрасно перенесли препарат. Вот потом, когда мы завершим полностью обсчет этого, то на следующий год, я думаю, что мы уже выступим с докладом по вот этому исследованию многоцентровому. Спасибо.